Moving right along, I would like to introduce our next speaker, Dr. Siobhan Kehoe, who is a clinical associate professor in the Department of Obstetrics and Gynecology here at Perlmutter Cancer Center.
It's actually pronounced Siobhan.
Oh, sorry, I did a very bad job with that.
It's a crazy spelling, Siobhan, but it's pronounced Siobhan. My parents, who were both born and raised in Ireland, gave me the crazy Irish name, even though their names are Kathleen and Vincent, and they were born and raised there, and I was born and raised here, and they gave me this crazy Irish name. But my parents think it's very funny that I have a job where I have to wear it on my white coat and on my badge, and that I'm not hiding it, but you know what, you take over what has tried to defeat you previously. So thanks for coming. Again, I mimic what Dr. Levine says. Thanks for coming out in the rain. It's GYN Cancer Awareness Month, and I think it's so important that that all of you, men and women, come out and hear about the things that you can be doing and the questions that you should be asking your physicians when you see them. So I, fortunately, am going to talk about survivorship. I do want to just briefly touch on the cancers that we take care of. So breast and lung and colon are the most common cancers in women. But you can see there that uterine cancer is the fourth most common, with about 61,000. And I think actually in 2018, it's up to about 63,000. And every year, it's getting more and more cases of uterine cancer. And you can see here that ovary cancer is not even on the list anymore of the most common cancers, but it definitely jumps back up to causes of death. And so while ovary cancer is not one of our more common cancers, it's definitely the cancer that we lose the most women from. And you can see here how uterus being high, uterine, endometrioid, corpus, it's sort of all the same. It definitely drops off the list. It drops down on the list of cancer-causing deaths. So again, corpus, endometrial, about 61,000, increasing every year, mostly because, unfortunately, obesity is an epidemic, and we have to realize that that's a major medical problem that leads to a lot of other causes. So keeping your weight down and keeping your BMI within a normal range is such an important thing for uterine cancer. Ovaries, about 22,000, and that's been staying the same pretty much every year. And then cervical cancer is way down on the list here in the United States, 12,000 cases. And does anybody know why that is? Because fortunately we have the pap smear and screening, and many people, many doctors abide by those screening, and we can catch a precancer and avoid having a cervical cancer being caused. And then you see the sort of the change in the deaths. So ovary cancer pops up to number one, 22,000 cases diagnosed, about 14 losses. But in uterine cancer, it's much different. We have many more patients diagnosed, but we lose less patients because we're able to catch that at an early stage and treat that. And then again, cervical cancer screening. So I get to talk about the fact that we are actually curing a lot of women with gynecologic cancers, and that's phenomenal. Women, as Dr. Levine said, who have ovary cancer are living longer and longer, and this is becoming more of a chronic disease. So the good news is we're curing more women, people are living longer, and so it's really important that we talk about survivorship. And so what is the diagnosis of survivorship? And I really like the NCCN, and they actually use the next reference, which is internal medicine's opinion about survivorship. But if you haven't ever gone onto the NCCN guideline, a website, they have a site for patients and they have a site for physicians. So I think it's a useful site to learn some things and maybe actually bring some stuff up with your physician. So survivorship, defined here by them, is from the time of your diagnosis, which I think is really, really a critical point, is that the moment you get diagnosed, you think about lifelong, you think about surviving through it and after. And so time of diagnosis through the treatment and after includes care of the family members, friends, and caregivers. I think that's so important. It is a team. It's not only a team of physicians and a team of all different types of physicians, but it's a team of you and all of the people in your life that work together to make the process of going through the treatment and then surviving after the treatment so important. And so standards, when you have a new cancer, when we want to prevent new cancers, and we want to follow and make sure that we catch a recurring cancer or can avoid it. We also want to surveil for cancer spread, recurrence, a secondary cancer, and then assessment for late psychosocial and physical side effects. A lot of the treatments that we do really have impending factors on you going forward. And I think as physicians, we really need to realize how important it is that, yes, we're going to recommend treatment, and these treatments are not necessarily going to be easy. Surgery is hard, chemotherapy, radiation, but the point is we can address the side effects that may occur after these treatments. Intervention for results of cancer and treatment, and coordination of care with your PCP and specialist. And really basically what you want to do is develop a survivor care plan with your physician. So here's the Institute of Medicine, and they talk about from cancer patient to cancer survivor. And again, transition from active treatment to post-treatment care is critical to long-term health. And it's so important that you talk with this with your physician, and not just your cancer physician, but also your PCP. And in this study, actually, which I think the first line is really quite exciting, in 2016 there were over 1.2 million survivors of gynecologic cancers. So yes, we diagnose people, but then we have survivors, over 1.2 million survivors. And so that's really an important factor for us to realize. We are going to take care of women going forward. Again, try to prevent a new cancer from happening, watch for recurrences, but also deal with some of the side effects that might have happened from our treatment. And the Institute of Medicine has a huge guidelines about cancer survivorship. And again, surveillance for the most recent cancer, screening for other cancers, general preventative health, and management of comorbidities from or independent of cancer treatment. And actually, this study sent out a questionnaire to gynecologic cancer survivors, and they said that they really wanted their oncologist to play an integral part of continued care. And of course, I want to play a continued part. And so it's really important that I reach out to PCPs and other physicians, and I have relationships with my patients' other physicians. And the key thing is that the patients truly, truly want that and are happy when they have that. And I think provides for the best global comprehensive care for the patient. So here's a long list of some of the effects after gynecologic cancer treatments. And they vary widely, and they can be psychological issues, menopausal symptoms, which can have some health risks, and the list is there, and obviously these can really be disruptive to any woman's life. Lymphedema, which is swelling of the leg, bowel dysfunction, nerve damage, persistent pain, skin changes, and physical distortion from some surgeries that we do. So psychological issues, these are understandable, and I think sometimes we're a little bit too afraid to talk about the fact that sometimes women feel guilty or feel shame that they've been diagnosed or have gone through a procedure that has really changed, changed their anatomy even. And of course, there's lots of long-term worries about fear of dying, anger, depression, anxiety. Our patients are strong women who care about everybody else and take care of everybody else in their life. And when now all of a sudden they're focused on themselves, they feel a lot of guilt and frustration about that. And I have to convince my patients, now it's your time to be the center of attention and let all the people that you've done so much for over all the years now be your caretakers and help you out as you go through this process. And so I think it's really important to, as a physician, to recognize that these can happen and address them. Sometimes patients don't want to bring them up to us. I urge you to talk about these things with your physician. And I try to ask as many patients as I possibly can about some of these symptoms and bring it up to them, because there are ways that we can treat them. I think one of the most important ways is referrals to other specialists who can help, like behavioral medicine, support group, social worker. My social worker is very active in my clinic because most of the patients that I see will require her to help out in some area, either with helping with their caring for older patients or they're caring for younger children, and so they need help too. And so the social worker is very active in my clinic. There's also anxiolytics, antidepressants, and sometimes people need to be on a short course to help get through some of these symptoms. And I also think now more than ever, integrative therapies, yoga, meditation, we know that helps across the board and can definitely help when patients are going through cancer treatment. Menopausal symptoms. Many patients who are perimenopausal or premenopausal will get diagnosed, and then we have to deal with the fact that we've now made them menopausal by doing surgery or giving them chemotherapy. And so these symptoms can be very, very life-altering. Hot flashes, night sweats. If you're waking up multiple times throughout the night and you can't sleep, and that's happening every night, that can really cause a lot of distress as the days go on. There are non-hormonal pharmacologic agents that we can use, and they've been proven in the literature to definitely help. They don't take them away completely, but they definitely significantly reduce the number and the intensity, and that really helps, as I see women saying, oh, I finally got 5 hours of sleep, which makes a big difference the next day if you've only gotten 2 or less interrupted every hour. So to get good sleep really then makes the next day seem a lot less overwhelming. There's non-pharmacologic agents too. It was really my patients that helped me realize how great acupuncture is for hot flashes. And I had a couple of patients, and when they actively went to acupuncture, they reported a decrease in their hot flashes. Exercise and weight loss does also help. And so these are easy things that we could put in and then discuss if you want to be on a pharmacologic agent. Intimacy after cancer is a very, very common problem, and the NCI estimates 40 to 100% of cancer survivors will have some form of sexual complaint. 30 to 90% with gynecologic cancers report severe, long-lasting problems. Many of them have had radical surgery that's really changed anatomy and can make intimacy difficult. And then many have had radiation, which also can affect tissue and tissue planes and make intimacy more painful. So it can also be lack of interest, low libido, painful intercourse, vaginal atrophy, and it's really common to have more than one complaint. So with pain with intercourse, it can be multiple contributing factors, and so it's very important that the physician do an exam and see if there's specifically something that we can treat, and vaginal atrophy actually can be treated. Anatomy can actually be addressed also, and if there's muscle tension, actually physical therapy for the vagina has really shown to make a big difference. Now you're probably all sitting there and my patients say, wait, you're sending me to physical therapy for my pelvis and my vagina? And I say, yes, and if you go, it works. And then they come back and they giggle and they say, I'm not going to go, and then they go and they come back and they say, it really does work. And so I think working with our colleagues over in onco rehab can really make a difference. And when we apply these treatments and people stick with them, it really works. And I have seen differences, which is why I'm very motivated to talk about these things and get you to ask about them, because there are options to help. So for vaginal atrophy or dryness, there's non-hormonal treatments, and different gels and oils and vitamin E and vitamin D can be used, and it really, if you do it routinely, will make a difference. There's also hormonal treatments, and basically using estrogen creams or tablets, and using hormonal treatment would have to be a discussion that you would have with your physician to say, is that beneficial, or would the non-hormonal be more beneficial? Treatments for other causes of painful intercourse. Some of our surgery or radiation can cause shortened vagina, but with dilators, if used over time, can definitely make a difference. Muscle tension, you can have relaxing agents, and as I just talked about, pelvic floor therapy, which if you go, does work. And with some types of pain, particularly the burning pain, which is usually from nerve damage, you can use these pharmacologic agents. So, the first step is to ask, and there's obviously barriers for discussing sexual health. Clinician barriers, sometimes we're focused on other issues and we don't think about it. Maybe we're even a little bit embarrassed to ask. And of course, patient barriers and sort of not thinking that they should ask, or again, focused on something different. So as I give these talks not only to patients and people, but other physicians, if we talk about it, we can usually come up with some sort of fix for it. And so the NCCN helps us do that, and they have a nice little checklist here with 4 questions. The male checklist is much longer and has many more questions. But this is easy if you don't really want to necessarily talk about it. You can right away give this and say, this is something we ask all our patients, and then you can sort of see the level, and then it's sort of an easier way to move into addressing this topic. And then the NCCN guidelines are also really good at kind of going through what options there are. And I put this up not so that you could see every one, but to realize a lot of these issues that occur post-treatment, post-surgery, post-chemo, post-radiation, are vague, and maybe sometimes we don't focus on them or don't want to talk about them, but there's lots of options to treat them, and I think that's the reassuring thing. And since women are living a long time after their treatment, we need to be addressing these things. So can hormone replacement therapy be used in gynecologic cancer survivors? Again, 30 to 40% of women will be diagnosed when they're pre or perimenopausal, and so treatment will make them menopausal. And menopausal symptoms can really lead to decreased quality of life. And is hormone replacement truly contraindicated in these women? The question is, will the hormone replacement, make occult disease start to grow? Unfortunately, there's no large studies to date that are prospective, that are good, that are the best type of clinical trials that we have, and they're probably not going to be done. And so hormone replacement after treatment for endometrial cancers generally has not been recommended, since most endometrial cancers tend to be estrogen dependent, and the concern is, can it stimulate occult disease? And I really think these are theoretical concerns, and we don't really have data. We don't have data to support, but we don't have data to not support. This was one study that was done. It was attempted to be a prospective randomized trial where they looked at women after surgical treatment, and they randomized to placebo, which is the sugar pill, versus estrogen tablets. And unfortunately, this closed to accrual because there was a study that came out that sort of went on primetime TV and said hormones are bad across the board, no matter who you are, no matter what you are, stop them. We've now realized that that data probably wasn't so correct, but it made this trial stop. And so it didn't meet its accrual, so it's very difficult to come up with a definitive answer if the clinical trial did not meet its initial enrollment. But we looked at, they did look at least the patients that they had already treated, and in the treatment group, the disease recurrence was 14 patients, where in the placebo group, it was 12 patients. So it was looking like it probably wasn't going to be contraindicated in people with stage 1 or stage 2, but unfortunately not able to get a definitive answer. There was another study looking at effects of hormone replacement on rate of recurrence in endometrial cancer survivors, quantify the effect of it on the recurrence, and so basically a meta-analysis looking at multiple different trials. One was randomized, but 5 others were just observational studies, which is, our best data is as a prospective randomized trial. The rates of recurrence, there was 19 of the 896 HRT users had a recurrence, and 64 of the over 1,000 controls had recurrences. So really, so equal, and so felt to be no significant increased risk. So what is the answer? I think that's still a question. I think going back to every case scenario, every case is independent on the patient sitting in front of you and what her risk factors are, and so important to have a discussion. But the total risk of recurrence after low-risk endometrial cancer is probably low with or without HRT, and data on which to base a recommendation for estrogen replacement therapy really is limited. But again, I think those that are for it will say that women who undergo menopausal symptoms can have quite life-altering poor quality of life, and it's something to consider even for a short course. And of course, those that are against it say data's limited and what does it do to the cancer? So a balance, as we do every day in clinical practice, is always balance the risks and the benefits that we know of for that individual patient. So lymphedema, just to address one other problem that can occur, is after you've done surgery, we were taking out the lymph nodes. This is a common thing in women who have breast cancer. When they took out a large number of lymph nodes in the armpit, then they would get swelling. The same thing can happen in the legs if we take out a significant number of lymph nodes in the pelvis, or if we give radiation therapy to the pelvis. And it's fluid that accumulates in the legs and in the limb. And if it can be quite clinically significant for some patients, causing pain, causing some difficulty with mobility. And so it's an important thing that we need to address. It can cause leg heaviness, again, decreased mobility, even skin changes. And you can see the risk factors there are age, a higher BMI, or dependent on how many lymph nodes were removed at the time of surgery. But there is treatment, and there actually are lymphedema specialists who we send patients to. Again, the team of clinicians and caretakers in the process of taking care of our patients. Easy things to do are elevate when resting or sleeping. We can actually manually drain the leg, where you sort of just massage the leg from the ankle up. There's compressive garments, which also sort of the theory is to help move the fluid out of the leg, and then certain exercises and actually moving the leg will also help. And like I said, referral to lymphedema specialists who are really great at helping our patients with the symptoms from lymphedema. So I'm just going to take I was asked to talk about survivorship, and I'm, again, always happy to get up and say we have many women that get diagnosed, but many women get through the treatment and survive. And again, our job is to care for them long term, prevent other cancers from happening, and also deal with some of the side effects that could have been, that are from our treatment. But just to talk about the 3 main cancers that we have, cervical and vulvar cancer. If you go to your gynecologist and you have your exam and he or she follows the pap smear guidelines, then you should not get cervical cancer, because with the screening and the finding of precancer and doing something about a high-grade precancer can then prevent a cervical cancer. So I can't emphasize enough how important it is to have your routine visits. Most of the women who get diagnosed with cervical cancer, the vast majority have not had a pap smear within the past 5 to 10 years. That's a very common factor that we see. And then, of course, there's the HPV vaccine, and my last couple of slides are going to be about the HPV vaccine. Endometrial cancer, again, related to obesity. So a BMI should be between 19.9 to 24.9. And I'm not going to go home and check mine tonight because it might be a little higher than that. But the point is, we really want to focus on healthy lifestyle. It's not dieting. It's eating right and being active, and focusing on weight loss so much is hard to do. And nowadays, I send a lot of my patients to not only medicine specialists in weight loss, but also surgical specialists. But I think the important factor is thinking about a healthy lifestyle in terms of healthy eating and activity. And if you're postmenopausal and you have any new vaginal discharge or bleeding, that is a red flag, and that needs to get checked out right away, and you need to be seen by the gynecologist. Ovarian cancer, fallopian tube, I just want to say a lot of people call it the silent killer, and if you kind of look back and listen to some of my patients, they will talk about having some symptoms, and so here's a list of symptoms: bloating, weight change, feeling full quickly, not being able to eat as much as you did before, some abdominal or pelvic pain, or even just new discomfort, urinary frequency or urgency, or changes in how you have bowel movements and bowel function. Now, you go out and you have Mexican, and the next day you might have a little bloating and you might not feel right and your bowel function may not be perfect, but it'll go away within the next day or two. So if these symptoms come and they last for even just a week or 10 days, you need to get them checked out. And often many medicine docs will say, well, let's see what happens in a couple of months. I would urge you to say, no, let's get that checked out. Let's do some type of imaging, because if these symptoms come, or a few of these symptoms come and don't go away over a course of 1 to 2 weeks for sure, then seek evaluation. So just again, cervical cancer prevention, do your exams, pap smear screening per the guidelines, and then the HPV vaccine. So who should get the HPV vaccine, or what is the HPV vaccine? We had first the Cervarix, which was just against 2 viruses. And just to take a step back, HPV, human papillomavirus, is the number 1, the number 2, the number 3, the number 4 cause of cervical cancer. It is highly related to precancers of the cervix and then cervical cancer. And now we also know that it's related to vulvar cancers and anal cancers, and now about 50% of head and neck cancers are associated with HPV. So this virus can have significant impact on men and women. We now have vaccinations for it. The first, as I said, was just against 2 viruses, but we know there's hundreds and hundreds of viruses. The second vaccine was Gardasil, and that was against 4 viruses. 6 and 11 are associated with genital warts, and 16 and 18 are the most virulent in terms of cancer causing. And now the vaccine that we use standardly in the United States is Gardasil 9, and it's against 9 different HPV viruses that we know are the high risk viruses. So who to vaccinate? For a long time, we were just vaccinating women. Didn't make a lot of sense to me at all. And now the recommendations are to vaccinate both really boys and girls, males and females, and we've seen that significantly reduce HPV infection. So females are recommended at the age of 11 to 12 and up to 26. So basically, though, we want to target kids before they would ever get exposed to the virus. And so the general recommendation is 11 to 12, because we think that hopefully that's a time when they haven't been exposed to the HPV vaccine. They actually do say you can give it as early as 9. And so again, I think this is important. It becomes individualized, but it's really recommended between ages 11 and 12 for both boys and girls, and up to 26 for females, and you go up to 21 for males, but you can also vaccinate to 22 to 26. So the point is, we want to get people vaccinated. And it can significantly, I think it will significantly impact the rates of HPV infection, precancer, and definitely cervical cancer. And again, here's just the recommendation by our society, the American College of OBGYN, target 11 to 12 boys and girls, 3 doses. Use the 9-valent. Even if you don't get all 3 doses, it's okay. At least 2 is good. Not recommended for pregnant women. And really, we saw a huge decrease in the prevalence of HPV. So everybody always asks about potential side effects. There are some local side effects: pain, swelling, a little bit of erythema at the site. And you can see here some fever, nausea, nothing that has been long-term or persistent side effects. So this was a physician in support of it, and I totally agree, strongly recommend the HPV vaccine. When my friends or family ask me about it, I say it's not whether or not to give it, it's when to give it. I think it's really important that we have all of our young kids vaccinated. And so for you, talking to your kids or your grandkids or your kids about the grandkids and sort of making awareness, I think is key. So I think we're going to hold questions to the end. So